Next, I would like to introduce our next speaker, Dr. Carly Levy, who is an Associate Professor of Pediatrics in the Division of Palliative Medicine at AI duPont Hospital for Children in Wilmington, Delaware, which is affiliated with the Sidney Kimmel Medical College at Thomas Jefferson University. She studied medicine at Warren Alpert School of Medicine at Brown University and completed her residency at AI duPont Hospital for Children in 2010. After working in hospital medicine, she joined the palliative care and supportive team at AIDHC in 2012 and completed a hospice and palliative medicine fellowship in 2014 at the same institution. She currently is a program director of the Hospice and Palliative Medicine Fellowship at AI duPont Hospital for Children and Christiana Care Health System, as well as a director of palliative care, palliative medicine education at her hospital. She is currently serving as the co-chair of the Policy and Advocacy Subcommittee for the American Academy of Pediatrics section on hospice and palliative medicine. Her academic expertise also includes teaching communication skills and promoting professional development for wellness and medical trainees. So Dr. Levy, I will turn it over to you. Thank you.
Thanks, Nicole. I wish I could see everybody's faces, but I hopefully one day will meet people in the future at a conference in person. So thanks for the introduction, Nicole. Nice to meet everybody. I think my first sort of, I guess the way to start this is, what is palliative care? A lot of people, when I introduce myself, they have a lot of questions. Either they have presumptions and they don't know what palliative care is, or they have presumptions about what they think it is. So I'm here to sort of define it and also perhaps dispel some myths. This is definitely one of the presumptions that people, think about when they hear palliative care. So I'm going to tell you, first of all, what we are not. I've had families say to me, does that have to do with the palate, or is that a foot doctor? We are not people who are here to convince anyone to let anybody die. We are not exclusively hospice oriented. I've heard somebody say, including providers, oh great, the Grim Reaper's here. Or are you the comfort team? My uncle had the comfort team. So we are not those things. So I'm here to dispel some myths. Myth one, palliative care is hospice. So the WHO defines palliative care and defines it well. It's the total care of an individual's mind, body, and spirit, and also giving them support. Hang on one second. To the entire family. It begins, and that's key, it begins when the illness is diagnosed. It's not for end stage illness, and it continues regardless of whether or not a patient receives treatment, treatment-directed therapies. Healthcare from a palliative care perspective is aimed at improving quality of life for patients living with life-threatening or life-limiting conditions. We are an added layer of support. We are here to partner with their primary doctors, and the goal is really to alleviate suffering. So, and we recognize suffering doesn't just happen physically, although with mitochondrial disease, there's a lot of symptom burden as the disease progresses. We're here for spiritual suffering and emotional suffering. And that's why it really requires an interdisciplinary approach, meaning not just physicians on board. Who's suffering? We recognize it's not just the patient, it's the family, but also staff. Often we're involved in pediatric patients with mitochondrial disease, but we are supporting the family as well as the staff involved. Another myth we hear often is palliative care is only for individuals who are close to dying. And we know that that is definitely not true. The model has really changed over the years. People thought that we only got consulted right at the end. But again, palliative care, you can see in the red, should begin at the very beginning. And for a lot of patients, symptoms aren't that significant in the beginning, so perhaps they don't need a lot of palliative care support. But over time, palliative care support might become more of the sort of frontline approach to helping patients with mitochondrial disease or any life-limiting conditions. Hospice is really at the end. It's an added layer of support at the end that is involved to help patients and families remain at home and stay comfortable. When should palliative care get involved? This is the old model. My apologies, the slides were flipped. But again, people used to think palliative care got consulted right at the end, and that is just not true. I don't know why my slides are kind of flipped, Nicole. Give me 1 second. I don't know why they're flipped from, this is not what I anticipated, but we'll just go with it. So a lot of people ask, you know, there's terms involved in terms of when to consult someone like me who's trained specifically as a palliative care expert. Primary palliative care is provided by primary providers. It's the nephrologist, it's the internist, it's the family medicine doctor. It's people who are sort of the frontline folks who are first meeting patients and families with, you know, a patient with mitochondrial disease and their families, and supporting them in the beginning. And then once it becomes out of their scope, that's when perhaps they might consult a subspecialist in palliative care, and that's secondary palliative care. Tertiary palliative care really occurs at the research institutions, institutions of excellence. This is permission from a family of mine. This was a patient with mitochondrial disease that I took care of for years. Her name was Callie. Her family's lovely. And, you know, she's just an example of how we can really be involved, you know, in terms of decision-making support. So as a lot of you are very aware of, the decisions change over time, whether it's decisions about medications or interventions, surgeries, you know, technology dependence. So these are conversations that palliative care specialists can really help navigate and serve as a sounding board to make sure that the plan moving forward is the plan that honors the wishes of the patient, but also the family if it's a child. Pain and symptom management, this is something we get involved in often for patients with mitochondrial disease. And sometimes it's incredibly difficult, especially with mitochondrial disease, to find the right therapies to help minimize pain and the burdensome symptoms that patients experience. We are communication experts, a lot of training in communication skills, so navigating these tough, open, honest conversations to help make sure that wishes are granted. And sometimes it's advanced care planning. Sometimes it's care coordination, so communicating with a lot of the providers involved. If there's many subspecialists, sometimes we can sort of make sure everybody's on the same page, and that we are continuing to honor the wishes of the family and the care plan matches the wishes. Hospice oversight does happen for patients who really have chosen to limit interventions, stay at home as they get sicker, and so that is something that we do, as well as end-of-life care. Who can provide palliative care? Lots of, and again, you know, as I said in the beginning, there's lots of different realms of suffering, and we recognize that everybody serves a different expertise to sort of make sure that we're paying attention to those prongs of suffering. So doctors, nurses, social workers, chaplains, all along the psychosocial realm and spiritual realm to make sure that we are alleviating suffering as best we can. And we also recognize that, you know, not all these resources exist everywhere. And so perhaps it's a nurse practitioner, and that is the palliative care team at one institution, and she's just aware of a lot of community resources to make sure that patients get referred appropriately. I always say, once you've seen one palliative care team, you've seen one. Our model at our hospital, we see inpatients, we see outpatients. We've really adopted to telehealth, especially in the era of COVID. And we do home visits as well. Another myth that we often hear is palliative care is primarily for patients with cancer. That is certainly not true. Even in the pediatrics world, you can see that we often get consulted for pediatric patients, and, you know, genetics alone is at least, you know, 22% of infants under 1 and 13% of the consultations within 10 to 24 years of age. Patients at DuPont, who do we see? So, you know, malignancy is the blue, but genetics and neuromuscular are the gray and red. So we are seeing really almost sort of split, and every institution is different. Patients or another myth, patients or caregivers have to choose between fighting for a cure or life-prolonging options and giving up. And palliative care means giving up hope. I hear that a lot. And that is just not true. Again, palliative care should be provided from the very beginning. With respect to pediatric patients specifically, there is a provision in the Affordable Care Act that is still in place, and it was created in 2010. So kids who are really at end stage disease, who are hospice eligible, can still get life prolonging therapies as well. I think a lot of people think, well, if I'm hospice eligible, that means I need to choose between hospice and TPN, or hospice and going back to the hospital and seeing my doctors. And that's just not true. For pediatric patients, you can absolutely have hospice and TPN and home nursing and trach vent dependence and BiPAP and everything that you want to make sure that your child stays alive as long as possible, but is also perhaps well supported from a comfort standpoint in the home. So that's, and there's models of that in the adult world too. The VA has certainly adopted it. And so it's growing, because I think people realize the burden of decision making, especially when patients are at end stage of their disease. Why should I have to choose between two levels of support that I want both? And it shouldn't be a choice. Everybody should have as much support as possible. Palliative care providers, I had mentioned that we navigate a lot of tough conversations. I think, I mentioned we are not about giving up hope. Sometimes we're about, having these honest conversations and reframing hope. Maybe we can't hope for cure. Maybe we can't change disease trajectories, but can we hope for relief in suffering? Can we minimize pain? Can we hope for the best quality of life possible? And sometimes when we're really at end stage, can we hope for a peaceful death? A little bit about our team. So we are 2 full-time pediatric hospice and palliative medicine doctors and 2 part-time. We have 1 nurse practitioner, a child life specialist, which I'm going to go in a little bit more detail about, chaplain, social worker, and fellow. We do provide a training program to the adult side too. So we do a lot of work with kids, and not just kids with mitochondrial disease, siblings of kids with mitochondrial disease. And I think that this is very applicable to the adult world too, because kids who are otherwise healthy but maybe have a parent with mitochondrial disease, it's the same skills about how do we support these kids, and how do we talk to these kids about either their parent who is sick or not doing well, or their sibling, or themselves. And so here's the general pearls that our Child Life really does a hard job at educating people regionally and nationally. So conversations with kids should always be child-led. We should never walk in a room with a kid and sort of have our agenda and our information that we want to share. It should only be around what the child wants to talk about, what the questions or fears or things that they're mulling over. We always ask children what they already know. Tell me what you know about what's going on with your body. Tell me what you know about what's going on with your mom's body. Answer a question with a question. Sometimes people fear the harder questions, and sometimes it might be, even the hardest question of, am I going to die? Tell me what makes you ask that question. Tell me what you're thinking about. So maybe it's following up with a question to really make sure you understand what they're asking and what they're thinking about, or getting to the root of what they're worried about. Reflecting back what they asked. So you're asking this question, did I hear you right? Only answer what they ask. I think, in our adult brains, we're so full of information and full of things, that presumptions about what people want to know or what they should know. And for kids, maybe it's just, am I going to have to stay is mom going to have to stay in the hospital one more night? And that's the only question they have. Or maybe it's about technology. Is this thing going to be attached to me all the time or sometimes? And that's their only question. And that's the only answer that we need to provide. We use real words, the medical words. We don't use euphemisms when we're talking about supporting kids, because they're going to hear these words and they're going to make assumptions about them. So we try to have doctors explain the medical words that they're using to make sure that kids aren't making up their own definitions. And it's okay to say, I don't know. You know what? That's a really good question. Maybe we should ask the doctor that. Let's have a list. Let's make a list of all the questions you have. So I think I went through some of this, but I just wanted to make sure how do you start the conversation? I've had parents, do you have any questions about what's going on with your body or what's going on with mom's body? Maybe it's no, and then the conversation's over, or maybe there is a question there. Anything you're worried about? So these are open-ended questions, and the answer is yes or no. And anything else, I always want to make sure, maybe they have more questions, and until they say no, and when they say no, I should say, that's when the conversation ends. this is some of the harder work that we do to support kids and siblings of kids with serious illness, including mitochondrial disease. So the child life specialist, she does memory making, which is incredibly important to make sure that the kids are engaged and supported. Molds. This painting in the middle was done of the sibling painted this. This was one of her favorite activities that she did with her sister at the beach. Her sister couldn't go in the water because some of the tubes that she was connected to, but she just sat with her at the beach and really appreciated the jar in the upper right. Unfortunately, was after her sister died, but she was able to have a jar of questions like, if I had my sister here, what were some of the questions I'd want to ask her, or what are some of the things that I'd want to tell her? So keeping the kids supported, I think, is really important. These are books that we often recommend to kids, even if they lose a dog, to be honest with you. It helps navigate conversations around loss. So that's some of the things that we do to support siblings. How can we help you, your child, your family? I think we ask a lot of questions to get to know each individual child, each individual family, because everybody has different needs. Everybody has different things that we can be helpful in terms of making sure that their quality of life is maximized. So we don't know until we walk in the room and start asking some open-ended questions. So that's it. That's my presentation about what we do, what we can do, and I'm open to any questions.
Thank you, Dr. Levy. How would someone navigate trying to find a palliative care professional, whether it's at their care center, at their doctor's office or hospital? This person has typed in that they had palliative care for her daughter while she was at Children's, but now that she's moved to an adult hospital, they can't get a palliative care professional. Any suggestions you might recommend?
Well, you can you can certainly ask the primary doctors involved. I would start there. Sometimes, and it's not hospice, but sometimes hospice programs have a branch of palliative care. So it's for patients who are not hospice eligible, but perhaps they want some home-based palliative care support for symptom management, some second set of eyes in the home. And again, it's scary because it sounds like, oh, they're affiliated with hospice, but they're actually a separate branch for a lot of these programs. So I would start with your primary doctors and ask and see if there's any local primary, or palliative care specialists. And if not, maybe they're affiliated with a hospice program.
Okay. This person said they tried to get palliative care from several places, and each one told me that it is only for homebound or cancer patients, which is that slide that you had put up earlier. One told me to go to a pain specialist. I don't know where to go to get help. They live in Michigan.
So again, if this person could start with asking their primary doctor, you can also email me. I'm part of a listserv. We can ask around. But usually if it's not individual adult, I'm assuming that this is an adult palliative care. It's harder to find adult palliative care providers. Pediatric palliative care providers are usually affiliated with institutions. But adult palliative care doctors, you should be able to find in the community or affiliated with a hospice organization. And I'm so sorry, because that's just not okay. Mm-hmm. And I wish that there were more access. And you're right, depending on where you live, sometimes access is much more limited in certain areas, which is not okay.
Mm-hmm. This is interesting. This person's asking, what do we do, or what resources are there for families where a given hospital's palliative care group does not have the philosophies and processes that you laid out here in your talk?
I'm curious what that means. Could that person expand a little bit?
If you're, yeah, Donna, if you can, maybe expand on that a little bit. Another person, does palliative care help with care coordination? This person says, my husband got disqualified for eye surgery due to a high A1C, and it's due to mitochondrial and complex conditions. So I didn't know if a palliative care person would be able to help with our coordination of care.
So again, it depends on the actual, I mean, yes, we definitely provide help with care coordination. Usually the care coordination that palliative care teams do is more about, okay, there's a medical option that the family's faced with. Is this the right choice? Let's talk to all the providers, make sure that all the providers are communicating. Maybe it's a family meeting, so let's get the family involved and we're all here together. So we're coordinating and making sure that all the providers are looped in, communicating. To get access to certain appointments, I would actually maybe talk to social work
Okay.
and the primary doctor. Those people can really navigate the healthcare system in terms of access issues. But
Okay.
if it's a question about whether or not to pursue certain interventions, or I'm hearing different messages from different doctors and I don't know which way to go and I need a sounding board, that's when palliative care can really help coordinate communication and the team.
Okay. This this is a important question, I think, and I think probably a lot of people have it on their mind. How do we get insurance companies on board? This person says they had to drop palliative care as they would not provide me with the same level of care, i.e. durable medical equipment, and it became harder and harder to acquire. Do you have any
So
thoughts on
I think that, I think it's more, I imagine, I wish this was more of a question and I could talk to these people, but
I
I
know.
think Medicare, especially in the adult world, it is a decision that unfortunately adults have to make between hospice. It's not palliative care, it's hospice and then ongoing life disease directed therapies. Hospices can provide DME, but again, you are foregoing certain treatments in the adult world in order to have hospice. Palliative care though, palliative care, insurance companies should be paying for palliative care. It's a subspecialist who is helping with pain and symptom management or advanced care planning. It's like seeing any other subspecialist. So again, if it's a question about reimbursement, maybe it's talking to social work to help navigate what the barrier is. So I wish I could understand more about what this person's asking, whether it's a hospice barrier or palliative care, because insurance companies should be paying for palliative care and disease-directed therapies. But once we get to hospice, it's really a unfortunate decision that a lot of adult patients have to make until things change.
Sure. Okay, this person came back. She said to expand with an example. The group sees palliative and hospice as the same for the cure attempts, i.e. none. My family member was taken off all meds but painkillers suddenly and would not consider putting them back on any pharmaceuticals, and the two are mixed up locally and on the Medicare website. So that person was in reference, this is a little difficult, was in reference to what do we do when the resources that we're dealing with aren't following the philosophies and processes that you laid out.
Again, I think when you're starting to talk, in the medical world, we call it deprescribing. When you start taking away medicine, that's hospice. That's not necessarily,
Okay.
hospice is one part of a very sort of late stage form of palliative care at end of life. But if you want to continue life-sustaining therapies, medications, they shouldn't have to start stopping certain medications. They only do that in the hospice realm.
Okay.
So how do you get on board? I think you're asking the right questions. You talk to the team, you include a social worker. Why am I being limited in terms of, I want to continue these medications, or my loved one wants to continue these medications. Why do I have to make a choice? I do know in the hospice world that hospice has to, part of Medicare will not, part of the Medicare requirement is that they will only pay for certain medicines. And so
Okay.
only within the world of hospice, we're not talking about palliative care, we're talking about hospice. That's when they start to deprescribe. So again, hospice is very different from palliative care in general. Hospice is sort of end stage, but it happens, and it's, until families are ready and patients are ready to really focus on comfort and forego life-sustaining therapies, recognizing they might not live as long, but perhaps the disease-directed therapies are only prolonging suffering. That's more the hospice mindset. Otherwise, we're in a palliative care realm. Like, I want to keep living as long as possible. I want to improve my quality of life. I'm going to keep taking these medicines, whether it's for my heart failure or my cancer or my mitochondrial disease, and I want to minimize my symptoms. That's more palliative care minded, if that makes sense.
Okay. So we got a question in through our chat window, and I'm not sure if this is applicable to you, but I'm going to ask it just to be sure. Are you familiar with dichloroacetic acid as a treatment? No?
No.
Okay. They're asking if this treatment would stop if they're afraid that the person would pass away. So I'm going to reference them back to Dr. Kara on that then.
Okay.
Okay, we have another one that typed in here. My son's father and I are separated. We cope differently with our son's terminal illness. I find it very difficult to discuss our son's future and the difficult choices that we all face one day. Do you have any suggestions for communicating with him on these difficult topics?
What about communicating with the child?
Yes.
First of all, thank you for asking that question. I think it takes a lot of courage and love to even ask the questions and want to have those honest conversations. Sometimes, and I've had many parents who are on different pages about how to have these conversations with kids, and it requires sometimes a medical provider to help parents both get on the same page about it. And really the general advice is that if your son has questions that he needs answers to, that we should be answering those questions, because kids tend to know when parents are hiding things from them. They tend to have more anxiety when we are not answering their questions honestly. And so I think, and there's more relief and hope when kids, especially adolescents, have these honest conversations, even in the face of a terminal illness. So we know that in the medical world, and it's sometimes hard for parents to get on board with that for so many reasons. But it might be helpful to talk to a medical provider to almost have that sort of healthcare expert to say, hey, for your son's mental health, this is how we navigate. And maybe your son has no questions and that's it. You tried, but you never know when that 2 a.m. sort of wake up, I do have questions. How are we going to handle it? And to be a team about it, because he's going to know if people are hiding things or skirting around the issue. So I think it's such an important question. And I would recommend that maybe pull in a healthcare provider, especially even a child life specialist or a psychologist or even just a palliative care provider would be really helpful to help you.
Okay. What about conversations amongst other adults in that same situation? I know that, they are divorced, and so they obviously don't live in the same household. Do you have any recommendations for how she would handle conversations with her ex-husband?
Conversations about their
Their
son?
son's illness, yes.
Well, I think everybody, that's a hard thing for me to answer without knowing more specifics, but I
Sure.
would say that I think everybody copes differently about their child's illness, and some parents want as much information as possible and some parents don't.
Mm-hmm.
Sometimes I'm having conversations with one parent about the big picture and all the decisions and how things are going to progress, and the other parent is one day at a time, and we have to honor that. And so maybe it's, helping recognize that we all cope differently. And if there's no urgent decision making that sort of I can only handle today is the way some people cope. And so it's trying to support each other, recognizing that we all have different needs from an information standpoint, from a coping standpoint. And so getting the support you need, but not forcing each other to talk about things we're not ready to talk about if it's not an emergency and we don't need to talk about it today, if that makes sense. So it's respecting each other's differences is what I would recommend, but making sure that at the very minimum, getting on the same page about talking to your son about it.
Yeah, that's
making
the important
sure
part.
Yeah.
Just to follow up with a question, the outside resources to turn to when the palliative care organization really isn't adhering to what you're subscribing to basically today, are you recommending them reach out to a social worker for some extra help or for their primary care?
Yeah, I mean, it depends on the need, the question. If it's symptom management, I would start with the primary care doctor for sure and see,
Okay.
hey, I had this issue that I wanted addressed. I presumed it would be addressed by a palliative care specialist. It wasn't. What can I do next? I would always go back to the primary care doctor and see, is this a social worker? Then they can really flush out what are the needs and how can we best support you? Maybe it is a social worker. Maybe it's a psychologist. Maybe it's, hey, we'll get a second opinion from a palliative care specialist I know down the road. So I would start with the primary care provider.
Okay. All right. I'm not seeing anything else, Dr. Levy. Nobody else has come up or popped up in our chat or our Q&A box. So thank you very
Okay,
much for your presentation today.
no problem. Thanks so much for inviting me.